Welcome to Module 3, Part 1 of Introduction to Diagnostic Medicine. In this module, we begin an exploration of body systems and the diagnostic tests that are used to diagnose or screen for certain diseases. Certainly not all of the diseases that are possible or all of the diagnostic tests that are possible will be reviewed in this class, but we will address some of the common and most frequently used diagnostic tests and procedures. You'll want to review these learning objectives and be sure that you can use them as a type of a study guide and that you are able to complete the action, define, describe, explain the different topics that are listed. We'll begin with hematology. The definition of hematology is, this is a medical specialty that relates to the anatomy, physiology, and pathology of the blood and the blood-forming tissues. The images that you see show you in picture form what whole blood would look like if it were allowed to settle, where you would see the red blood cells or erythrocytes at the bottom, the white cells and platelets, which we call the buffy coat, in the middle, and then the liquid portion, which would be plasma or serum if the specimen is clotted, in the upper portion. The cells or formed elements of blood include the red cells, platelets, and the white blood cells. We'll be talking about each of these, how they contribute to health and disease, and how we evaluate them as we go through Module 3. First, it might make sense to talk about where blood comes from and what does it look like in vitro. So, in vitro means outside of the body or in the test tube. In the adult, blood cells are formed in the active bone marrow or the red bone marrow. As an individual ages, from childhood to adulthood, this active marrow comes to be a much smaller part of the total bone mass and ultimately is found only in the sternum or chest bone and the crust of the hips. We call that the iliac crest. Inside these bones, or this active bone marrow, are structures that allow the formation of cells, the red cells, the white cells, the platelets. So we would consider the bone marrow basically to be the factory where blood cells are formed. If we collect blood in a test tube, as you see in the image on the right, whole blood will look pretty much like you expect blood to look like. And again, if blood is allowed to settle, you'll see the red blood cells at the bottom, the plasma at the top, but where are the platelets and the white blood cells? If you think about the previous picture, previous discussion, the layer of white blood cells and platelets, or the buffy layer, is generally very small. In most cases, too small to be seen visually. And when we talk about the reference ranges or normal values applied to these forms elements, or the size of the cells themselves, you'll understand why we really don't see them in the normal person's settled whole blood. This is an example of a microscopic view of a bone marrow. So if marrow were removed from the interior of the bone with a special kind of needle, processed in the laboratory and stained, and viewed microscopically, it would look like this. You see a general distribution of different kinds of cells. You see some clear areas that represent fat. This is what a normal bone marrow would look like. A laboratory scientist or a pathologist would be able to identify each of these cells and provide a distribution number for them, which would help the provider determine if their patient was healthy or diseased. In a bone marrow where a person has leukemia or the opposite, where they are not producing sufficient cells, the bone marrow would look very different. It could be crowded with many of the same kind of cells and virtually no fat or clear areas, or it could be missing many cells and look kind of barren. It makes sense that if an individual is suffering from a hematologic disease and we've ruled out or are unable to diagnose the disease based on simple or less invasive tests, we would collect some bone marrow and examine it microscopically. So in other words, if something is wrong with the product, which are the blood cells, it makes sense to go to the factory. What you see here are the tools or needles that are used to collect bone marrow from the interior of the bone. You can see an example of a bone marrow specimen being collected from the the iliac crest. Bone marrow looks a lot like blood. That should make sense to you, although it will have some spicules or pieces of bone in it. And then at the very bottom right, you can see examples of what is ultimately prepared and examined in the pathology laboratory. You may have observed personally or in some other circumstance that blood seems to be collected in different colored tubes. And the purpose of the different color stoppers is to identify the chemical that's inside the tube. So a tube that has an anticoagulant in it will be identified with a specific colored stopper. The purple color that you see here is consistently used for EDTA. EDTA is an anticoagulant that is almost exclusively used for hematology. It keeps the blood in its liquid state and allows for the proper examination of the blood cells that are present. The red color stopper that you see contains no anticoagulant, and so blood collected in this kind of a tube will eventually clot. The cells and the platelets will clump together. The liquid portion we call serum. And if we wanted to examine the cells, which we do in hematology, this clotted blood will not be useful because all the cells will be deformed and squished together. We won't be able to examine them as we should. So what happens in vitro to blood that is not anticoagulated? The answer is it clots, as you see in the red top tube, and the cells become deformed and uncountable. The plasma portion is serum. Let's talk for a moment about one of the most commonly performed tests, certainly one of the most commonly performed hematology tests, and this is the complete blood count, or CBC. The CBC is a panel of tests. You should remember the term panel because it includes 10 different tests. The white blood cell count, the white cell differential, the red cell count, the hematocrit, hemoglobin, red blood cell indices, and platelet count. And then if you look at the image on the right, which is an actual printout from a panel, a CBC panel, you'll see additional types of tests that are calculated or presented. All of these are useful in helping the provider, clinician, determine if their patient is healthy or if they are suffering from some sort of a disease, be it a viral or bacterial or hematologic disorder. So the CBC, complete blood count, a panel of different tests, all designed to assess the quality and quantity of the cells found in whole blood. Cells are counted in the hundreds of thousands and millions, and back in the day, this was done manually. There's probably virtually no laboratories that do any manual cell counting anymore. So if you can imagine microscopically enumerating millions of cells, you can imagine how much room for error there was in such a procedure. So cells of the blood, white cells, red cells, and platelets are counted with automatic cell counters or automated cell counters, and you see a picture of one here. The blood is introduced into the instrument. The instrument has multiple ways of counting or identifying cells, both numbers and sizes, and even the contents of those cells, and then provides for the laboratory scientist information, which you see on the right, where we see how many cells are counted: white blood cells, red blood cells, platelets, the types. So that would be the neutrophil, lymphocyte, monocyte, eosinophil, and basophil. In the percents, you'll see a hemoglobin and hematocrit. That tells us about how many red cells are present, and then some other calculations and information that help us know more about the size and shape of the red blood cells. The scatter plot, or the picture that you see kind of in the middle of this slide, gives the scientist some information about how many of each type of cell are present, and if they're small or large, or if there are some abnormalities. What you see here is a very normal looking CBC with white cell differential. Sometimes it's really useful to know what types of white blood cells are present, so not just how many, but what types. And that is the white blood cell differential. The way this is done is to take a specimen of whole blood that's been anticoagulated in EDTA, because we want to be able to examine the cells. It's spread on a glass slide and stained, as you can see in this picture. And microscopically, the scientist is able to view the white blood cells, the red blood cells, and the platelets, and evaluate them for morphology. So what do they look like? And also get an estimate of how many of each type are present. And we call that a differential. The differential is relative, so it does depend on the technologist and their skill in counting, but it gives the provider some information about the relative number of each type of cell present. And you can see the bottom picture has labeled white blood cells. This is important because increases in different types of cells give us information about the type of disease process that the individual may have. The cells you see here are normal, and they look normal. It's not likely in real life we'd see one of each type of cell in one microscopic field, but this does give you an idea of what is seen through the microscope. It's important to know also that normal values, the range of normal that we compare the patient to, are age dependent, and that children have different white blood cell differentials than adults. Remember, the white cell differential gives us information about the types of white blood cells that are present, and this is in addition to the number. Let's talk just a little bit about the erythrocytes. So erythrocyte is the scientific name for red blood cells. You might be interested in knowing that a single red blood cell travels about 250,000 times through the body before it's destroyed. The typical red cell lives for about 4 months. The length of time that a red cell lives gives us the ability to collect blood from an individual and who is a donor and donate that to, or provide that to, a recipient who is in need of whole blood. If the blood cells lasted a shorter period of time, blood banking or transfusion service would be less possible. So the red blood cells are enumerated in the millions per cubic millimeter. A cubic millimeter is a tiny, tiny amount of blood, less than a drop. 4.6 to 6.2 million red blood cells per cubic millimeter. You can see why counting these manually could be a very tedious task. We say that the red blood cells are anucleated, That means no nucleus. They're formed in the shape of a biconcave disc. You see that in the picture here. The biconcave shape allows a greater surface area for the cell. Red blood cells carry oxygen. Red blood cells contain hemoglobin, which is the protein that makes them appear red. And hemoglobin has an affinity or an ability to carry oxygen. So the more exposure the surface of the red cell has to oxygen, the easier it is for that hemoglobin molecule to attract oxygen and carry it to the tissues. It's important to know that red blood cells also have variations in normal for age and sex. We did talk about reference ranges and normal values and how important it is to understand that there are variations per age and sex and from region to region and laboratory to laboratory. So remember, when reviewing patient values or even a case study against a published set of data, you need to be sure that you're comparing that data to the correct reference range. These are a few terms related to red blood cells that you should know. They tell us about the number and quality of the red blood cells. So too few red blood cells means anemia. Anemia is a general class of disorders that just represents inadequate numbers of red blood cells. Too many red blood cells is called erythrocytosis. Whenever you see the suffix cytosis, that means there are too many cells. In this case, too many red cells. Too many red cells can also be quite dangerous. The blood can become thick, sludgy, difficult for the heart to pump, and there are some specific diseases such as polycythemia that represent a severe erythrocytosis. It's also useful to know if the cells, the red blood cells, are normal size or too small or too large, and also if they are normally shaped like a biconcave disc or if they're abnormally shaped. Size variation is referred to as anisocytosis or varying cell size. We'll talk a little bit about the variation in red blood cells and how that can help diagnose disease in a little while. Shape variation is called poikilocytosis or various sized or shaped cells. So poikilocytosis can also be very helpful. For instance, sickle cell disease results in cells that are shaped in the size of shaped like a sickle crescent. And that poikilocytosis can help the clinician identify the type of disorder that their patient may have. So you should be able to define anemia, erythrocytosis, anisocytosis, and poikilocytosis. One of the tests in the CBC is a hematocrit. So we've talked about counting the numbers of red cells. It's also helpful to have an estimate of the percent of red cells in whole blood, and that's the hematocrit. It's sometimes called the packed cell volume. Packed cell volume is really just representing the way the test is done. And the way the test is done manually is to collect blood in a small glass tube and centrifuge it at a certain time and speed, and then evaluate how much of the column represents red cells and how much of it is plasma. And you can see an example of that in this picture. The more or taller the column of red blood cells, the higher the hematocrit, the higher the percent of red cells in whole blood. The hematocrit is relative. So that means if the person is dehydrated and they don't have enough liquid plasma, their hematocrit could become elevated, but it isn't really elevated. They're just dehydrated. So that's an artifact. A person's hematocrit will become decreased in cases of anemia. Remember, anemia means not enough red cells, or if they're bleeding due to blood loss. It makes sense that blood loss causes anemia. Anemia is just a name applied to any set of disorders where the person has insufficient red blood cells. You should recognize what the hematocrit measures, the relative percent of red cells in whole blood, and also a little bit about why we call it a packed cell volume and why dehydration might impact the hematocrit. Here you see it. Here's an example of what a normal anemic and polycythemic hematocrit might look like. Number 1 represents a normal hematocrit, 2 is anemic, a very low percent, and 3, polycythemic, a very high percent, approaching 70%. You should also note that the reference or normal range is different for males, females, children, and newborns. So we see age and sex variation. Newborns tend to be a little bit dehydrated when they're born, so they have a higher than typical hematocrit as compared to, say, a child or an adult. Another test on the CBC panel is the hemoglobin. In the hemoglobin test, we are measuring the concentration, or grams per deciliter, of hemoglobin. Remember, hemoglobin is the protein that gives blood its color and carries oxygen. This protein is composed of iron and protein. So when a person becomes iron deficient due to blood loss or nutrition, they will have less hemoglobin, since iron is an essential component of hemoglobin. We describe hemoglobin as chromasia. So what is the color of the cell? When a cell has less hemoglobin than it should, or less than normal, we say the cell is hypochromic or undercolored. You can see in the pictures a normal chromic red blood cell, nice and pink. About a third of the center is clear or central pallor. And on the bottom picture is a hypochromic red blood cell, many hypochromic red blood cells. And you can see the cells are quite clear in the middle, lots of central pallor. This represents an abnormally low amount of hemoglobin, as we might see in anemia, hypochromic. You might wonder about some of the numbers that are also included in a CBC report. Of most interest to us are the MCV, mean cell volume, and MCH, mean cell hemoglobin. These help us to know something about the size and hemoglobin content of the red blood cell without actually having to look at them. So without having to do a microscopic differential. The mean cell volume, or MCV, tells us how big the cell is. So if we have an MCV that is below the normal range or standard range, in this case it would be less than 80, we would say that the cell is microcytic or too small. We often see microcytic cells in some types of anemia, such as iron deficiency. The MCH is the mean cell hemoglobin. So how much hemoglobin per red cell? You can see it's measured in picograms, so the weight of the hemoglobin. A low MCH means we have a hypochromic red blood cell. In this case, it would be less than 27. So that tells us that this person is not producing enough hemoglobin if their MCH is low. And we have a hypochromic red blood cell, and we can make some at least initial assumptions that there is probably perhaps an iron deficiency or some other problem that results in a hypochromic anemia. So, MCV and MCH are calculations that lead us to know if a cell is microcytic or macrocytic, or if a cell is hypochromic or normalchromic. White blood cells, as we've previously discussed, are counted as part of the complete blood count panel, or the CBC. The term for white blood cells is leukocyte, and sometimes we abbreviate it WBC. It's important to examine the white blood cells for the diagnosis of infection, monitoring treatment such as chemotherapy, and just to screen for disease. Screening is defined as identifying illness or disease in an otherwise asymptomatic population. If you remember, symptoms are the information that the patient reports about themselves. A CBC with the white blood cell count can help verify those symptoms. The normal white blood count is between 5,000 and 10,000 per microliter, and you should also know that a microliter is the same thing as a cubic millimeter. So you want to watch for variation in reporting units when interpreting reference ranges or normal values. Remember, erythrocytes are counted in the millions per cubic millimeter, and white blood cells much, much less than that. This helps to explain why, if we allow whole blood to settle, we don't see a layer of white blood cells. There's just so many fewer. What you see in this image is a depiction of the fact that all blood cells come from a common parent or stem cell. You've probably heard about stem cell therapy and being able to harvest stem cells and cause them to grow into a different kind of a tissue. That's how that works with blood cells. A common stem cell is influenced by chemicals in the blood to become either a lymphocyte or a myelocyte, white blood cell, which or also could become red blood cells and platelets. It's interesting to see how differentiation causes our cells to produce or grow differently, and also a little bit to understand how leukemias can be difficult to diagnose because they may all come from a single immature, undifferentiated cell. It might be a little bit more than you want to think about right now, but you should definitely understand why we examine white blood cells, what a leukocyte means, the general reference range or normal range for white blood cells, and also remember, a microliter is the same thing as a cubic millimeter. Some more terms to think about. Too many white blood cells is called leukocytosis. So just like we talked about too many red blood cells being erythrocytosis, leukocytosis means cytosis, an excess of white blood cells. So our white blood cells are responsible for responding to infections. They do increase in trauma and stress. It's a natural reaction. And they abnormally increase when a person has leukemia. This peripheral blood smear that you see demonstrates increased white blood cells or leukocytosis and is probably representing a leukemia because you see many immature and similar looking white blood cells. That's an indication of leukemia. Leukocytopenia is too few white blood cells. So this is just as dangerous as leukocytosis, just as anemia is dangerous and represents too few red blood cells. So leukocytopenia could be due to a bone marrow injury. Remember, if the factory is damaged, you're not going to get enough of the product. A viral infection, exposure to toxins, chemicals. So what do you think happens to people who have too few white blood cells? Hopefully you've thought about that for a moment. So if we know that white blood cells are essential for fighting infections, and we don't have enough of them, the likely outcome is going to be repeated infections. People are succumbing to routine infections that a healthier person would have no trouble fighting off. If you have ever had a relative or an acquaintance who's been treated with chemotherapy, you may have been asked to stay away if you have a cold, or possibly to wear a mask if you visit. The idea behind that is that chemotherapy damages all cells, including blood cells. And because of that, people often become leukocytopenic and more susceptible to infections. So now you know the right scientific term for too few white blood cells and what happens to people when they are leukocytopenic. We talked in the earlier part of this lesson about a differential, and that the white cell differential is intended to estimate the types of white blood cells present. So in this next little bit of learning, we're going to talk about the different types of white blood cells and what they do and how they impact health and disease. So the first cell is the neutrophil. There's a nice description of what the neutrophils do, and then a stained peripheral blood smear. So you can see what they look like to the scientist who's examining them. Neutrophils are the most numerous white blood cells. Their function is to destroy bacteria, mostly. So we say they're phagocytic. We see increases in neutrophils when people have infections. So for instance, strep throat. But we also know that people can develop what's called a neutropenia, or not enough neutrophils. And again, they would be susceptible to infections that may not bother a typical person. The eosinophil is also a granulocyte. We call these granulocytes because they look like they have granules in them, and they do, and these granules are useful for the various functions of the cell. So in the neutrophil, the granules are bacteriostatic, or cytic, so they are intended to destroy bacteria. In the eosinophil, the granules have function in allergy and the release of histamines and things like that. We see increases in eosinophils when people have parasitic infections and also in allergies. And you can see in the description from the National Institute of Allergy and Infectious Disease, eosinophils contain granules that kill cells the immune system has marked for destruction. The basophil is the least number of white blood cells, the smallest number, usually only 1 or 2 per 1,000. And these, the granules in the basophils are involved also in allergy and inflammation. One of the chemicals in the granule of the basophil is histamine, and histamine increases blood flow during an inflammatory response. In most people, again, basophils are very small in number. So these are the granulocytes. You should have a sense of what they do and how they play out in number. Neutrophils being very numerous, eosinophils less, maybe around 10%, basophils very few, 1 or 2%. The lymphocytes are the other major category of white blood cells, and the lymphocytes are important to the immune system. Although the lymphocytes look similar when we examine them microscopically, there are distinct types. So the T cell is important in recognizing antigen or foreign particles or foreign substances in the blood and presenting it to the immune system. T cells sometimes help the B cells make antibody, and sometimes they are what we call cytotoxic and actually destroy pathogens or abnormal cells directly. At the end of this slide, you should pause the playback and watch the linked video of cytotoxic T cells at work. B cells are the lymphocytes that produce antibody. So when a person is exposed to a pathogen, say measles or some viruses, not too many of those, or some other bacteria, they will prepare antibody, and that antibody will forever recognize that antigen from that disease, that pathogen, and destroy it. So this is, in a very simplified form, the basis of immunization. Immunization causes B cells to produce antibody. That antibody protects the individual against any future exposures to that particular disease or pathogen. Pause your playback and watch this video of the cytotoxic T cells at work. I'm sure that you will enjoy it. The last of the white blood cells are monocytes. We call monocytes macrophages when they're in the tissues, and they spend a lot of time in the tissue. They're kind of the cleanup agent, the vacuum cleaner of the white blood cells. In the circulation, or peripheral blood, we call them monocytes. Monocytes and macrophages can move back and forth, and we give them different names depending on the tissue that they're found in. So that sometimes can be a little bit confusing, but if you think that their major role is to help clean up the pathogens and keep the tissues and the peripheral blood free of debris. Those are the monocytes. By the way, macrophage translates into big eater. So that goes along with the idea that the monocyte or macrophage is responsible for cleaning up the circulatory system, blood system, and tissues. Here again is the picture of normal blood cells. You've seen them several times now. You won't be expected to identify blood cells morphologically, but you will be expected to have a basic understanding of the role of each of them and why an increase in one might represent some type of disease versus an increase in another. And finally, we'll talk about platelets. So platelets are not really cells at all, but they're fragments of cells. The scientific word for platelet is a thrombocyte. Platelets are derived from the same stem cell as the granulocytes and the red blood cells. You can see that in the graphic. And the cell develops into what we call a megakaryocyte. And the megakaryocyte typically only stays in the bone marrow. And little fragments of that megakaryocyte break off and form platelets. And those platelets circulate. Platelets are essential to blood clotting. And we say that they are important in primary hemostasis. You might have seen commercials on television for antiplatelet drugs. The purpose of antiplatelet drugs is to prevent platelets from sticking together. This is really important in people who have coronary artery disease or cardiac disease because those little platelets stick together and form a clot, a blood clot in the coronary arteries, and then can cause ultimately a heart attack because they block off circulation to the cardiac muscle. Recognize platelets as thrombocytes, recognize that they are fragments of cells versus whole cells, and that they are essential to proper blood clotting. And sometimes they clot too much, and we have to provide medications to prevent additional platelet clumping. As I said, platelets are essential to blood clotting. But when a person has a platelet defect, they're not going to overtly bleed, but they'll demonstrate what we call defects of primary hemostasis. So that looks like bruising or purpura or petechia, which are basically micro hemorrhages under the skin. You're familiar with bruising, and bruising usually represents some damage to the blood vessels and the surrounding tissue, and can represent issues with platelets. Now, if you get a bruise from an injury, that's due to trauma. But if you find somebody who is bruising as in this picture, without injury, they might have a platelet problem. And maybe they don't have enough platelets. Maybe their platelets don't function properly. Petechia usually represents some disorder of platelets and sometimes the blood vessels. And again, this might not be a word that you're familiar with, but it represents microhemorrhages under the skin, so little pinpricks of bleeding, and this can be quite severe. Sometimes petechia represent other things such as allergic reactions too. Recognize these two words as related to platelet function and platelet number and defects. So platelets are counted in the range of about 140 to 400,000 per microliter, quite a lot more than white blood cells, but substantially less than the millions of red blood cells. You can see them in this picture as the little purple spots on the peripheral blood smear. So remember, they're not real cells, they're fragments of cells, and this is a pretty normal amount of platelets. If they were clumped together or very large or many fewer of those, that might be indicative of some kind of a problem with platelet production, not enough being made, or platelet function, they don't behave properly. The term for too many platelets is called thrombocytosis, so you should be recognizing that cytosis suffix by now. And too few platelets is called thrombocytopenia, and you should also be recognizing that cytopenia suffix. We already said that platelets are integral to hemostasis, and when people have way too few platelets, so less than 20,000 per microliter, so that's about a seventh of the lower normal range, they can have spontaneous bleeding, and we'll often see that bleeding in their gums and mucous membranes, maybe nosebleeds, things like that. People don't usually develop this kind of thrombocytopenia unless they have a bone marrow disorder or if they're being treated with chemotherapy or have some other type of disease. So remember, platelets are essential to controlling bleeding, and severe thrombocytopenia can result in spontaneous bleeding. And you should also recognize the words thrombocytosis and thrombocytopenia. We've covered a lot of territory here, talked about the entire CBC, almost all of it, and the components of the CBC. So in your next module, you'll start looking at hemostasis. But for now, you want to complete your Module 3, Quiz 1, and any assignments or discussions that are outlined in the course module list.